Good evening, everyone. My name is Kevin Hahn. I am a simulation fellow at NYU Langone Health and a member of the Med Ed committee of the APAMSA Alumni Board. This now marks the 7th year of our bootcamp series. Um, the whole point of our bootcamp series is that we noticed that there was a wealth of resources dedicated to helping our students ace our med school clerkships as well as our STEP exams, but it was much more difficult finding teaching material dedicated to this window when we're transitioning to sub-internships or the internship. So I hope that in the next 2 hours, we'll be able to give you some tangible clinical pros as well. It's an honor to have with me three stellar residents, Dr. Sai Mupparaju from Emory University, Dr. Rahul Kathard from Temple, and Dr. Rodan and Mecano from William Beaumont University to help us give today's teaching on our core topics of emergency medicine, which is the best field of medicine. I will go ahead and hand this over to our National Board student leaders, Kelly and Alan, to kind of give an orientation on what today's format is going to look like.
Thanks, Kevin. I'll just start sharing my screen real quick. All right. Thanks again for coming to our boot camp session, and thank you for giving that intro, Kevin. We have, after this, just one more boot camp session on radiology next weekend. So if you've been to some of the previous ones and if you enjoyed them, check that one out as well. It'll be really good information no matter what specialty you plan on applying into. Um, and just brief logistics. Feel free to interact as much as you want during the session. Any questions that you type in the chat, one of the other speakers will hopefully be able to answer in the chat. And if you want to raise your hand and have a question that you want to ask, we encourage that as well. Just raise your hand and someone can acknowledge you and feel free to ask your question. And without further ado, I'll have all of our speakers just give a little intro about themselves as well.
Hey, everyone. So again, I'm Kevin Hahn. I grew up in Los Angeles, born and raised, and I ended up doing my undergrad at UC San Diego, got my medical degree at Western U Comp Mona, and then did my residency at New York Presbyterian Queens. I'm currently doing a 2-year fellowship at NYU Langone in simulation, but I'm also doing a master's in health education. After this year, I'll be starting as an assistant program director at St. Barnabas in the Bronx. Outside of work, my passions have recently transitioned into marathon running, triathlons, Ironman. Basically, I'm an Asian glove bucket. I'm just a stereotype here. Just give me a Celsius.
Hi guys, I'm Simon Mupparaju. I apologize about my camera. I tried. But I was born in India, but I grew up in Sewanee, Georgia. Went up to the Northeast to Dartmouth for undergrad and Jefferson in Philly for med school. I'm currently a PGY2 at Emory. I was in APAMSA Region 3 director, followed by training under Kevin for membership VP from 2020 to 2023. I have an interest in global and social EM and currently working on potentially doing an OA rotation in India. That's still in the works, but if you want to talk about it, let me know. There's a pretty robust global program at Emory. And then outside of work, love coffee. If you want to talk about the types of fermentation, let me know. I can nerd about it for days. Cooking, listening to murder podcasts, horror shows. Boxing is a new passion of mine, helps with the rage and raving.
Hey, I'm Rahul. I'm from Chapel Hill, North Carolina. I stayed in North Carolina for my training. I went to NC State and UNC for undergrad and med schools, respectively. And now I'm up at Temple University, currently finishing my second year, about to start third. Career path for me, I was a biomedical engineer in the past and then got scared of doing too much math. And so switched into medicine and wanted to be a little closer to people. Um, and then almost did peds. Now I'm scared of kids. I think you ask most community EM folks, they're terrified when someone younger than 10 walks in with a serious complaint. Outside of work, I like cooking, but more importantly, eating. I generally like moving around, the stereotypical EM physician. And then I like to play a little bit of music in my free time. I'm trying to figure out that guitar lick to Sinners, if anyone has seen it. It's been stuck in my head all.
Oh, it's a good movie, good choice. I'm Rodan Mecano. I was originally actually born in California, but my hometown I claim is Grand Rapids because I moved when I was about one. Um, did my undergrad at University of Michigan, did a master's at Boston University, and then med school at Michigan State. And now I'm a PGY2 and incoming 3 at Beaumont University here in Metro Detroit area. I'm non-traditional career path. I did some public health work in the Philippines prior to getting involved with medical school and getting involved with the PAMSA, first as diversity director and then diversity VP and then leadership committee chair. After residency, hoping to do an ultrasound fellowship and never really had an interest in PED, but also just wanted to say, yes, scared of children also. Outside of work, following the stereotype of young physicians into climbing, bouldering, lead, any type, reading books mostly about the state of the world, nuclear war, and apocalypses, TV movies like everyone else, and making craft cocktails. So I can recommend you a drink after.
All right. So today's goals, we have a lot to go through in these 2 hours, but basically it's how to get you guys to think like emergency medicine doc. We're going to be going through a few resuscitation tips, giving you some ideas of how to necessarily talk to consultants. And then after all of that, we'll talk about what EM looks like to the current state of emergency medicine is now, as well as what future goals will look like. We'll give you guys a few tips on how to study outside of your shifts, potentially some resources. And lastly, we'll go into some Q&A regarding any questions that you guys might have on our experience, how to get into emergency medicine, how to love it.
All right, guys. So I'll be starting us off by talking about the framework for the EM physician. And essentially, the way you think in EM is very different. You prioritize and are constantly triaging. You assume every patient is either dead or dying. You have to triage your patients simultaneously because you're going to have a multi-patient load. And you need to know how to assess them and figure out where they land in your list. And you'll have a lot of patients that come in with a chief complaint that is completely not what they're coming in for. So you have to be pretty much prepared for almost anything. All right. And then going into the next slide, I like to think about this as like your walk towards the elevator or your elevator thoughts. Whenever you're in an elevator, you're kind of just thinking about the next task that you're doing or where you're headed. And I want you guys to start practicing that. And I still do it too. Look at someone's vital signs and look at their chief complaint. Think about it. What are your elevator thoughts? What's your differential? Start practicing and prioritizing. Go from what's going to kill them first to what's going to keep them in a hospital to can I discharge them? Think about all those differentials. And then look at your history. That can tell you a little bit too. And then walk into the room and just take a second to look around the room. Look at the patient, look at what's hooked up to them, and you'll be able to learn a lot. When I did my MICU rotation, I remember one of the fellows telling me right before she graduated, she could know exactly what was going on with the patient by looking at the drips, whether they were intubated or not, if they had any supplemental oxygen, and almost always figure out what the diagnosis was. And if you practice this, you can know pretty quickly, sick or not sick, which we'll go into that shortly as well. And then as you leave a room, what are you going to do? Where are they going? And you got to keep people moving. You have a waiting room of 60 to 100 people most of the time nowadays in any hospital. And you have to keep people going. What's occupying this bed? Where can they go? and what can I do to expedite that rate limiting step? So going into the next slide, you'll have quite a few backups and things to fall back on, and algorithms and heuristics. But be careful with heuristics. You'll learn that more as you go through your training. But for now, they are pretty useful. Do a quick chart review. And what do you include in it? I want to know past medical, allergies, past surgical, and then medications. Typically, that can tell you kind of what's going on with the patient. If you can look at medications, if that's the only thing you have to look at meds and allergies. You can pretty much figure out what's going on with them from there. Look at the patient. Are they sick or not sick? And this can be more nuanced once you hit the gray areas of medicine where like they could be sick, they could decompensate, but regardless, sick or not sick for now. If they're not sick, you got time to think. If they're sick, get 2 large bore IVs, put them on some O2, get them on a monitor, and get a glucose. That's one of the major vital signs that we often forget. If they're not sick, what's your algorithm then? And this is what I was talking about. What's going to kill the patient today? What is most likely, and what's going to keep them in the hospital versus can they go home? And in order to do those, you need to figure out what labs or imaging are required to figure out what their dispo is. And then again, admit or discharge, and if discharge, how to do safely. And this is something that not many other physicians have to think about as in depth as ER physicians. You have to make sure that your patient is educated in what they need to do and what they need to look out for to not come back, or what they need to do and come back for if they're really, really sick and turning the corner in a bad way. They need to be educated and they need to know. And you have to take the time to do that and write it out, speak it out. It's really important. Return precautions are very, very important and just as important as your workup, if not more. So let's go to the hard stuff.
So let's think about one of the most common chief complaints we get in the emergency department: chest pain. And just like Sai was mentioning, if you've got the opportunity and it's not an unstable patient where you're immediately called to the bedside, take your second, do your chart review. Look for their meds. If they've had past EKGs or someone hands you an EKG, take a look at it. If they have past cardiology visits, did they have a recent stress test, anything that can give you a little bit more information. But let's say you walk into a room and, doc, I've got chest pain. They've got their hand clutched over their chest. And if you remember from any of your step exams, Levine sign, we've got Adam Levine doing it right here. Maybe they're not looking so good, okay? And if we go to our next slide here, we wanted to check for a couple things. One, let's say you walk into a room, they're not responding to you. First thing you want to do as emergency medicine physicians are our ABCs: airway, breathing, and circulation. Check for a pulse. Check if they're breathing. If either of those things aren't present, go ahead and start CPR, hit the blue button, call for help, call nursing, call for the crash cart. Keep on advance the slide. Let's say then they are responding to you. They may, they're responding to you, you look at the vitals and determine sick or not sick. And like I was mentioning, this is something that as you start your residency and continue through your residency, you'll have more experience with and be able to make better decisions on as you build your clinical gestalt. But walking into the room, there's a lot of information you can get from the patient that way. But for any of these big chief complaints, whether it's chest pain, shortness of breath, what have you, we have our top can't miss diagnoses. Because at the end of the day, our role as emergency medicine physicians is to rule out any life or limb threatening problems. So you can just kind of go through and advance the whole slide and kind of teach or go through each of these diagnoses specifically. Now, the differential for chest pain is broad, and it's good to think of all of our can't miss diagnoses. The first one being acute coronary syndrome, right? You think of your unstable anginas, your STEMIs, your NSTEMIs, and the things that we need to think about here are our workup, right? If they've got active chest pain, we're seeing ST elevations. They've got maybe an elevated troponin, heart score that's elevated too. We want to start give them the aspirin, consider talking to cardiology, call your attending, maybe think about activating the cath lab. The second thing to think about of somebody who's having chest pain, maybe they're feeling short of breath, maybe their blood pressure is a little bit low, we can think about cardiac tamponade. And one of the triads that we try and remember, try and think about from our exams is Beck's triad. If they're hypotensive, if you put your stethoscope on the chest, if they have muffled heart sounds, maybe some distended neck veins, this is something you can add a little bit higher on your diagnoses. A big thing that we can do as emergency medicine physicians is take that ultrasound to the bedside, put it on their chest, and check. You can see if they've got evidence of tamponade on the ultrasound, and maybe that can emergently, maybe that means they need an emergent pericardiocentesis, and that's something you can talk with your attending about, talk to cardiology about, and even do yourselves in the room. The third thing to think about are acute aortic pathologies or dissections. These are the people that you're thinking classically severe chest pain. It's radiating through them from the chest straight into the back. They might be diaphoretic. They may have come in with a recent syncopal episode, right? Think about potentially unequal blood pressure in the upper extremities. They may be diaphoretic. Big thing here is blood pressure control. You want to decrease their heart rate, decrease the blood pressure, so we can ensure that we're limiting the shearing forces that are going on the vessels to limit the dissection if it is present. And the big thing that we need to get here is also a CTA to confirm the diagnosis. Another one of our can't miss diagnoses are pulmonary embolisms. PEs are something that you always kind of have to have in the back of your head because they may not always present as pleuritic chest pain, someone who's short of breath, someone who's hypotensive. It might just be someone with unilateral lower extremity swelling. They might be just a tad tachycardic. It can really sneak in there and get you if you're not thinking about it. Big things to think about here, same thing with before the tamponade, is you can take an ultrasound, you can take it to the bedside, look at the heart, and see if you see D sign or Mecano sign, which is kind of bowing of the septum, impinging on the right ventricle. There's a whole algorithm for pulmonary embolism and D-dimer, which we'll kind of get into, but the big thing here is, get your CTA, your CTPE, if that's what it's called at your hospital, and then order heparin and consider thrombolysis. The next one to talk about and to think about are tension pneumothorax. Think of, either your tall, lanky, skinny individuals that may have developed these spontaneously. Think of your patients coming into the trauma bay after some sort of traumatic injury. You may not hear breath sounds on that side, but something to kind of think about too is these chest cavities. If you're not listening carefully, you might hear echoes or you might hear breath sounds on the left side of the lung, even though that lung is down just because it's referred over from the right side. So especially these busy trauma bays, it's important to listen carefully for those lung sounds to make sure that they're equal. And again, our friendly ultrasound is very useful here. You can take the linear probe, put it on the chest and look for lung sliding. You can look for the Sandy Shore sign or the barcode sign to see if there's any evidence of the lung moving there. Initial treatment, you do your needle decompression, and then definitively you would put a chest tube in. And a less common one, but something good to think. Commonality, it's something that I haven't seen as much of, is esophageal rupture. These people might be coming in for hemostasis, severe pain. Think of your alcoholics, people with a history of vomiting, right? That might be because of their pain there. You'll definitely need to have a surgery or GI consult to help you manage their care. Now, these diagnoses are a ton of the can't miss diagnoses, but not every patient is going to be coming in with these particular cases. So you also have to think about other causes of maybe less deadly chest pain that may be equally as severe. Think of your herpes zoster, your older ladies or older population. They might feel a lot of pain there. Look for the rash. Myocarditis, pneumonias, musculoskeletal strain, anxiety, substance use and abuse. chest pain is a very broad differential, and it's good to, when you're walking into the room and doing your chart review, to have all of these things in mind, and then really try to hone in based on your clinical yourself exactly what your workup needs to be. We'll go to the next slide. I'm just trying to click through the whole slide. So your chest, yep. So your chest pain workup, your starter pack, EKG, chest X-ray, will tell you a lot of information. The EKG will give you tons of info on if it's ACS. You may see something for pulmonary embolism. It might show you evidence of right or left heart strain. Chest X-ray will help you with pneumonias, pneumothorax. I'm a big fan of ultrasound, as I mentioned on the slides before. I think it is incredibly useful at the bedside to rule in and rule out a lot of diagnoses and give you a lot of information. Lab-wise, think of your troponins for ACS, D-dimers for your pulmonary embolism workup. The CT is our friend, the donut of truth. We made fun of all the time the fact that, we scan everybody, but there's a lot of things that we got to look for we can't miss. And in terms of treatments, treat their pain. It might be musculoskeletal, give them what they need. If it's ACS, give them morphine to help reduce their stress, reduce anxiety, and then risk stratify, as Kevin said in the chat here. We use things like the heart score. You can advance the slide once more. Or PERC and Wells criteria, all good to have in your head as you advance, but MD Calc is your friend. There are tons of guidelines and protocols. If your hospital has Epic, a lot of these might be built into your Epic skin already to use and automatically chart. But this helps you risk stratify both for your workup, but also for when you're giving discharge instructions or admission, or trying to argue for an admission with your hospitalist team on how sick or not sick the patient is.
All right, so let's take it away with shortness of breath. So when you guys walk into the room, and the biggest issue and the thing that we want to make sure you guys take away is understanding the primary survey. For someone who's in shortness of breath, you need to know and recognize whether or not they are in respiratory distress. Are they can't breathe? How fast they are breathing? Next slide. Part of this initial impression is going to look at how is their oxygenation? Are they hypoxic? Do you need to put them on supplemental oxygen and then call for help? If you don't call for help, if you don't put them on oxygen and then you call for help, they're still desatting there and you're preventing them from getting any better. A lot of times when it comes to shortness of breath, sometimes we think it's a primary pulmonary issue. Shortness of breath can be a whole host of things. It can be AFib with RVR, giving them palpitations, and for that reason, they're short in dyspnea on exertion. It could be CHF. They're having pulmonary edema and pleural effusions that's causing them to be short of breath. Or it can be, as we kind of said earlier, be like pulmonary embolism. It can be pneumonias that we're looking for. These are things that we want to meet out from the patient's history, but also correlate with what we see in our patient's physical exam. Now, shortness of breath, you're going to hear a whole host of lung sounds, whether it's your asthma, COPD, your significant wheezing, but potentially also in your kids when you're dealing with stridor and you're having that upper airway obstruction that you have to worry about. For these sorts of patients, the workup is pretty similar to what you will see with your chest pain. You're going to have your chest X-ray, your EKG, getting your labs, but also make sure you grab an ultrasound. A lot of the times when I was a resident, I thought that ultrasound wasn't as useful, especially when it came to what I thought was shortness of breath. But I have been burned multiple times seeing these patients and only realizing, man, this was actually a cardiac issue. I should have used ultrasound and helped this patient get what they need much faster. All right, next slide. So we'll talk about a few adjuncts to respiratory support. Often enough, EMS is going to bring a patient in on nasal cannula or on a non-rebreather. You might see other machines like the high flow nasal cannula as well as BiPAP. These are your non-invasive PPV or positive pressure ventilation. I will say this, if you see a patient on a non-rebreather mask, do not let them stay on a non-rebreather mask. If you let them stay on a non-rebreather mask throughout their whole ED admission, ED stay, you admit them, they will die. These are lessons that I have learned from COVID, from patients who are happy hypoxic, and all of a sudden you realize that they have become a code blue in the corner while they're being boarded. So transition them from their non-rebreather either down to a nasal cannula or to something more, something that has settings on it, like a high flow nasal cannula or BiPAP. Next. So BiPAP is one of the biggest things that helped us, especially during COVID. And you can use BiPAP in a whole host of issues, from asthma, COPD, to even CHF. Now, the idea behind BiPAP is that it provides respiratory support. What is this? It helps with patients' work of breathing when they're having fluid in their lungs or having difficulty moving air from outside into their lungs. Unlike a ventilator machine, what we're going to be worried about here is something called the delta pressure. That is the pressure that is being pushed in, as well as the pressure that is being pushed towards the patient while the patient is exhaling. So this is inspiratory pressure, expiratory pressure, and that is going to be what gives us our delta pressure, or the actual changeable number that reflects on how much how much a patient is able to breathe in terms of volume. Contraindications to this are going to be whether or not they can tolerate with this. If they're too confused, they can't breathe with this, they are clearly going to vomit and potentially aspirate what that vomit is, then that's very difficult, and that's not a patient who is not ideal. These are patients who you need to make sure have a good seal. So patients with significant facial trauma, burns are not good for this. But you should also consider that patients who are hemodynamically unstable in terms of their blood pressure should not probably go on BiPAP without additional resuscitation first. The idea behind this is that giving BiPAP or intubating a patient adds positive pressure to their pulmonary circuit and actually decreases the preload of blood going to their heart. So you can quickly drop a patient's blood pressure and cause them to go to a cardiac arrest if you do not prepare them for that. If they're too sick, then we have to go to intubate. We'll quickly talk about high flow nasal cannula. So high flow nasal cannula is great in that we can give large volumes of oxygen with a small tinge of positive pressure from this. For kids, I know kids make us scared. It's going to be approximately 1 to 2 kgs per liters per kg, whereas for adults, usually we start around 40 and go up as needed. This is going to be, again, for a primary oxygenation or perfusion problem where we don't want to be giving them too much positive pressure. So these are great for people who have pneumonias, pulmonary hypertension, pulmonary embolism, as well as interstitial lung disease. All right, so now we get to intubation, which is the hotshot procedure that everyone loves when it comes to an emergency department. When we are in emergency medicine, we are the demigods of airway because we have to deal with sick airways. We're not like anesthesia where they have their patients for the full pre-op and 24 hours without any food. We have to deal with the sickest airways and the patients who are not necessarily optimized for this sort of intubation. So when we have to intubate, I want you guys to remember this one mnemonic: soak me. What is soak me? Suction, at least 2, because you don't know if you're going to have to do suction while you're going in, and if you accidentally goose the tube, you can put it there as what we call a SALAD, which is suction-assisted laryngeal airway decon, but also suction to go ahead and lead and clear your airway as you prepare and take a look. You want to make sure the patient is pre-oxygenated. You have them on a nasal cannula, right, that you're pre-oxygenating them for at least 5 minutes and blasting that oxygen. It's not 4 to 6 liters. You're blasting it at 15 to wash out all of the nitrogen that's in their airways. You're going to need your airway equipment, which is usually your direct, but also your video, as well as your adjuncts, LMA. You need to make sure all of these items are going to be near where you are so that it's easily accessible so that you can quickly switch if you ever go into any sort of hiccup. Positioning is very important. The last thing you want to do is have a patient go in the coffin position. Patients die in the coffin position. If you can ideally sit them up, put their head above where their pylorus is, then when you paralyze them, you have less to worry about all their stomach contents now surprising you as you're trying to intubate them. You want to think about what medications you're going to have the patient on. There are a lot of medications that we use in terms of for induction as well as for paralysis. As you guys learn, the timing, duration, the benefits, those will all come with your experience on your sub-I. But understand that there are certain ones that are kind of a go-to. I personally use ketamine as well as rock because ketamine is great. It's one of our emergency medicine favorite drugs, and it has a pretty good hemodynamic stability that we like in terms of intubation. Rock uranium is great because it's a long duration of paralysis. And lastly, you want to set up an end tidal. Next slide. All right, the items that you're going to have for your intubation, you have your laryngoscope, you have your Miller, which is the straight one, as well as the Mac, which is a C because it's curved. You want to go ahead and make sure you have an appropriate tube, lube, and your 10 cc syringe to that. Now, as far as the stylet, if you're using a laryngoscope, if you're not using the hyperangulated, which has its own specific hyperangulated metal stylet, there's a different technique for that. But if you're using a regular direct laryngoscope as well and a regular tube, you can certainly use a regular stylet or the bougie. Recent studies have said that there's a higher first pass success chance at intubating a patient if you practice with the bougie. The bougie is great because it has the curved end at the end and it allows you to feel when you're in. So even if you're intubating blind, which should not happen, but you can still have that as a backup. All right, last. Intubation in real life is not a let's hit it and go. The whole process about intubating is a dance that starts 15 minutes before you get to the patient, ideally, unless this is a patient that is a resus and needs to be done. As soon as you make the decision to intubate, you want to go ahead and put your patient on oxygen, then pull up all your equipment. You want to make sure you have all the people around you and then communicate. You communicate to your resident, communicate to the attending, nursing staff. This is my plan. I have this tube, an 8.0 tube, and I'm going with direct first. My backup is going to be my bougie. If not, I have an LMA. Patient is hooked up to with and being bagged or on given nasal cannula or an non-rebreather mask to pre-oxygenate them. I have all my adjuncts here. If not, and I don't make it on the first time, resident is going to go ahead and get this. To quickly answer this question, that's the last question about bougie versus hyperangulated. Hyperangulated is specifically used when you're using video laryngoscopy with a hyperangulated blade for that. This is most ideal when you're dealing with trauma patients who are in a C-collar because the manipulation and positioning of the patient's head to align all those axes is a little bit more difficult when you have to protect the C-collar, their C-spine. So if you're using a hyperangulated blade, you have to use the hyperangulated stylet. Those are not interchangeable. But if you're going direct, you can certainly go with the bendable standard stylet or a bougie. Both will work.
All right, switching gears just a little bit. I'm going to talk about two things that are kind of high volume. You'll see these all over the place. I think statistically, this is a higher, more common presentation in the ER. And I think the most important thing to think of when you're thinking about abdominal pain is you have to remember that you're covering both the most minimal and least life-threatening things, such as I ate some rice that I left out, from like when I went and got lunch yesterday, to my aorta is ripping apart. So I think, as mentioned before by Cyan, Rodan, and Kevin, when you walk into the room, I think the biggest thing is pausing and just thinking about everything you're seeing, right? How is the patient appearing? What are the vital signs you see on the monitor? When you sign up for the patient at your computer, do they have a complete set of vital signs? You will often notice that sometimes the fever or the temperature is not done. Anything that you're missing on a vital sign is crucial. There's a reason you need all of those. As you get into there, you talk to the patient, like every physician, the key to this is a good history. So really hammering down what is the location, figuring out specifically which area. You're going to get this a lot where they say, I don't know, my whole belly. And you're like, where would you say? And they'll point in like a stripe across the belly. And like, you have one finger, pick and show me where do you feel this pain the most? And that really helps kind of understand how you're going to build your differential. Another important thing when you're hammering down sort of timing, onset, location, and pain and progress, you can kind of see, is this pain moving around, and then get into your other questions that you're going to naturally do through your history, right? Associated symptoms, nausea, vomiting, diarrhea. Can they eat? Can they tolerate PO? Have they had any urinary or bowel changes? And then the other historical things I think commonly missed are trauma histories, medication switches, or recent surgeries. One thing I would put in here that I'll also touch on the next page, part of this is you have to look at their belly. There's countless times where people will say, oh, I've been fine. No recent surgeries. And you open up and you look and you see they have like lap scars in their belly. And you're like, what's that? And they're like, oh, took out my gallbladder. And sometimes people have different definitions of what they define as surgery. They might not see a laparoscopic surgery as a surgery. It's always helpful to look. So once you get through your other symptoms, you start to think, you're thinking, in the actual abdominal cavity, make sure if you're, right upper, epigastric, left upper, that involves bottom of the lungs, the heart, all those pathologies that Rodan just talked about. Make sure you keep those in the back of your mind. Kind of lower abdomen, don't ever forget, especially on patients who have testicles, a torsion can absolutely present as pain that's referred up, or even pain like, clots, high up DVTs in the femoral area can also present as this kind of pain. I think the type of pain here, I think we often kind of get lost in our sort of, is it pinching or stabbing or burning? That helps a little bit. I think another thing that really helps is triggers. And then the most important thing is this continuous or is this coming and going? Because that could really help you figure out, if it's an abscess or an infected area, that would kind of expect it to be kind of low continuous with clear spikes. Or if this is something that's related to intestinal motility, you could see clearly kind of completely resolving and then coming back. You'd see that most effectively in like peds with intussusception. So next, kind of going into the workup of abdominal pain. On the next slide, we have this is something that I would encourage you to have studied or thought of, so that whenever someone says, hey, I'm having left flank pain, you're immediately going to, diverticulitis, kidney stones, pyelonephritis, ischemic colitis as the watershed areas down there, things like that. So you already are starting to ask those next questions, right? If someone had just said that, you can immediately start like, what are your clot sources? Do you have AFib? Have you ever had problems with blood clots? Things like that. And that helps you target your differential. So when people say you get that first, HPI that everyone learns, the old carts, and then I think the most crucial part that like kind of gets to that next step thinking is as you start to say, okay, they're telling me right upper quadrant pain. What's my differential? What targeted questions can help me, knock things out or add things in? If they say right upper quadrant pain, and then you say, do you have any surgeries? They say no gallbladder. That solves some issues. So going into our next slide, kind of how do you work this up? I think one of the most crucial things, you start out with your exam. One of the tips that I've learned, if you push slowly, people notice pressure, but they'll notice rapid changes in pressure much faster than they will a slow change. When you're doing your abdominal exam, push in all 4 quadrants. You push in the most painful quadrant they're concerned about last. And just make sure you're slowly pushing. That really helps avoid the, if you jab anyone in the stomach rapidly, especially when we're crunched for time in the ER, it's going to hurt. And so you'll end up with this pan positive exam, and you'll sort of push you down wrong, or roundabout workups. So I think being really cautious with your exam, making sure you're looking at the skin. And then for folks who are sicker, folks who are older, folks who have any other conditions that you would, maybe cause you to suspect that their exam's not going to reveal everything, I would encourage you to not forget to look in the inguinal area. Neck fash, Fournier's gangrene can hide down there, and they'll have sort of this lower abdominal pain they report. And also testicular torsion, like we mentioned earlier. Getting into the next thing, this is kind of the basic lab workup for abdominal pain. This specifically biases a little more towards upper or sort of vague right upper, left upper, plus flank. This is kind of your whole shebang. I would add or subtract the lactate based on how sick this patient appears, right? If they're tachy, hypotensive, febrile, you're going to throw in the lactate because that pushes you down sort of an infectious SIRSI pathway. If not, you can hang on to that until it reveals itself. Ultrasounds, as Rodan mentioned, a crucial point. I would say I use it now as sort of an extra part of my physical exam. If you see a chief complaint on the board and you say, hey, they probably could benefit from an ultrasound, I would encourage you to bring the ultrasound with you when you see the patient. Do your history, do your exam, do the ultrasound right there. You come back and in your presentation, you're switched from, oh, my plan is to do a right upper quadrant ultrasound to here's my history, here's my physical, here's what my ultrasound showed. It showed hyperechoic stone in the neck of the gallbladder with atropic gallbladder and pericholecystic fluid. You've almost negated the need for the rest of this workup. And then other things, I think the big question in abdominal pain is when to scan and when to not. I think this is one of our most common places where that decision becomes the crux of your presentation. Are you going to scan this person? Are you not? For younger people, folks underneath, I would say 50, 55 plus and sick with lots of chronic comorbidities kind of falls into the 65 plus, where it's your risk benefit of getting a scan causing radiation. But if it's risk benefits worth it, you don't need to get the scan. I think the big thing there, it's clinical judgment. You will practice this throughout the way. And I think to echo what Kevin said, remember these are ultrasounds. We are not radiologists. Radiologists do wonderful things with their scans and can read them on a level that we cannot. But it is useful to have yes/no questions, kind of like your physical exam, right? You hear crackles, you're not saying this is clearly heart failure. We're going to have them follow up in clinic. You're saying that's weird. We're going to have to dig down further. So I would encourage you to use your ultrasound like that. Just remember, I think, to recap abdominal pain, if we go to the next slide, here's sort of the can't misses. The things you think of, perforated viscus, cholecystitis, appendicitis, ruptured AAAs, Fournier's gangrene, like we mentioned, ischemic colitis, pancreatitis. And then for patients, never forget pregnancy, and specifically ensuring this isn't an ectopic pregnancy. If you have a positive pregnancy test and abdominal pain, you then must have a way to say this pregnancy is comfortably intrauterine and that you're not going to be discharging someone who has a pregnancy outside the body. And then as you're thinking through all of these differentials, just make sure to remember a lot of this is sort of, you'll get used to it on nuance, but illness experience, I think, is important, right? If someone is normally, let's say a frequent flyer always asks you for turkey sandwiches, they come in today, they don't ask you, and they're saying abdominal pain, that raises a little hair. So I would say abdominal pain, big barrel of concerns. Make sure it's not something life-threatening, then you can go down the natural progress like Sai and Rodan both mentioned. Switching gears in a similar vein, headaches. So if we click through these, I think headaches fall into these three sort of boxes. This is how I like to approach headaches. There's your emergent causes. There's, the bleeds inside the head, blood clots, whether that's stroke or sinus thrombosis, and then basically infection are kind of your big three. You need to do something immediately. Urgent causes that would say, hey, you probably need to stay in the hospital, but we're not, activating neurosurge and things like that. Masses, intracranial hypertension, temporal arteritis, vasculitis, glaucoma or ocular concerns, and then other cerebrovascular pathologies. One thing I think we always forget in the winter months, at least personally, especially when folks are indoors all the time and old heaters, don't forget your carbon monoxide poisoning. And then as far as other things are sort of treatment related, you can see things from hydrocephalus, drug-related issues, or post-traumatic that are non-hemorrhagically associated headaches. And so when you're trying to figure out when someone comes in, if you go to the next slide, when you store it in, I think this is your big question, right? Is this something that fits a primary headache history and physical, right? Cluster headache behind the eyes associated with tension, stress, migraines, your pound mnemonic, and how they should usually have migraines. Someone coming in at 45 and saying, oh yeah, this feels like a migraine. I've never had a migraine before. It raises some questions. And if they have some sort of unknown headache pathology in the past, that's important to think. And then secondary headaches, I think, are the ones that we worry about, right? If we can say, I often say for headache folks that, hey, I can't tell you what's exactly causing this pain right now. I can help you feel a little better. What I can tell you is this is less likely something that's going to be life-threatening. And these are the things I think our job as a emergency physician is to get through. So if we're clicking through the workup on the right, click a couple times on the slide, we'll get through. We start out, I think the most important part for headaches is getting through that history. Again, I think this falls into a very similar vein, such as the abdominal pain, really getting a good old charts. Is this old? Is this new? What's different? getting through your exam, the things that are going to be dangerous are going to change your mental status. They're going to have neuro exam findings. If you do a good HE and T exam, looking in the ears, behind the ears, the things that are, I feel like these are all the steps that like 3 seconds to look in the ears, or you're like, oh, that's probably not going to matter. That ends up making a difference at once in a while, and that'll be your, save of the month. And then when you're thinking about imaging similarly to headache, to abdominal pain with headaches, you're thinking about risk factors, right? What's your pretest probability? This person comes in photophobic, holding their neck, they can't move, and they're like, this suddenly started when I was taking a shower. You're like, you're going to scan that, versus a sort of waxy, waney, on again, off again associated with when I'm not drinking water. Maybe it's not a great time for the donut of truth. I think when you're thinking infection, never forget that part of your headache workup includes the LP down the way. And that kind of ties into a neuro findings, especially with this. Next slide. For workup and treatment, if you click through this, I think the big thing for imaging is just look at your CT reads. If you're going to get it, look at it fast. I had a case last week where this guy was really pleasantly intoxicated with a little like bruise on his head. Fun guy to talk to. Got the head scan because he was found down with a scratch on his head. And the radiologist messaged me like 40 minutes as we were in the middle of bringing him to the trauma bay and activating him to have the neurosurgeon look at him more closely. So they get behind. They read a ton of scans in the ED in the hospital. Don't forget to be looking at your CT reads. We're not going to find. It's harder to find super subtle finds, but someone who has like a florid subdural hemorrhage, or subdural hematoma or subarachnoid hemorrhage is going to be something we can see. Don't forget your treatments. This is sort of a basic approach: NSAIDs, Tylenol, fluids, antiemetics, triptan, steroids. Most programs have sort of their own approach they like. I would just encourage you to have a good headache approach. What's your migraine approach? First round, second round, third round of medications. You'll learn this from folks you work with. You'll also develop kind of what you like to do. And then I think one of the last things is reassessment, right? If they are improving with your medications, you can say, be reassured there's no findings that are concerning you for a secondary headache, and they're looking better, then I think you could maybe start to push yourself towards, yeah, this person could probably follow up outpatient, figure out where this is going on an outpatient basis. But if you've gotten all the way to the end of your migraine cocktail and you're like, I'm not scanning this, and they're like still in splitting headache, unable to be doing other things, then I would encourage, for this and any other chief complaint that you're evaluating, don't ever be afraid to rebroaden and say, hey, wait a minute, let's pause here. Did I narrow too fast? And I think that's the biggest part for headaches. So moving into the trauma bay, where you've activated your head bleed.
All right, so let's talk about resuscitation. Next slide. The big thing about resuscitation is on-site communication. And coming in, whether you're a sub-I or a PGY1, the big thing is to observe, listen, and communicate. There's going to be a lot going on. There's a lot of roles. There's a lot of jobs to do. Okay. And I think trying to find your niche or trying to find what you can be responsible for is going to depend on whatever program or shop that you're working out at that time. Next slide. All right. So this is sort of a common, like a diagram of some common like roles, designations, leaders. And I would advocate, if you're under sub-I or as an intern, really watch how either the attending or the team leader, PGY 2 or 3, is leading and commanding the room. See how they're delineating roles and establishing that communication with each of the team members. Because I think at the end of the day, that sort of mental model on making sure the team leader is thinking one thing and the rest of the team is thinking the same thing with them, what they're worried about, what they want to do next, really helps these resuscitations go better. So when any medical resuscitation comes in, let's just start with like a potential like CPR patient. You're just going to do your ABCs. You're going to take the EMS call, like get transferred over to the stretcher, and you'll have one resident or physician or an RT at the head of the bed. That's the airway physician. That person is going to do the A and B component. If they need to be intubated or if they're already intubated, just to make sure that tube is in place, check for their breath sounds. The kind of looking around at the other positions around the bed, the team leader will often designate to have either a tech or a nurse establish 2 large bore IVs if those are not already present. And then there's sort of that float exam or procedure physician or resident. This is sort of the layout for my program. Well, we're very lucky to have the staff to kind of provide each of these roles for us. And that procedure exam resident might have the POCUS at the bedside to do a quick fast exam, to do a quick cardiac echo, or to start throwing a crash line in if needed, or an ultrasound line, or an interosseous line. The roles vary again, and this may look different depending on where you go or the resources you have at your institution. But I think focusing on what you can do as a PGY1 or as a sub-I is ask, like on your first day of the rotation or your first, at the beginning of your shift, ask what, if these patients come in, what they think that you could help with. At my institution, we are happy to let med students intubate patients. We're happy to let PGY1s have the head of the bed, do the ABCs, do the intubations, do the fast exams, do POCUSes, all with like a supervision. And I think even just taking a moment, if you're maybe a little bit shy or want to get your bearings, the first time one of these comes in, just observe. I think there's a lot of learning that can be done, and something that I wish when I was a PGY1 or as a sub-I, I'd taken more time to just kind of see how the senior residents were controlling their room, because I think that's a soft skill that's very important in medical resuscitation that we don't always get discrete training on. And lastly, with any resuscitation, we do our best to resuscitate. We don't always have the best outcome. Next slide. And sometimes the rooms end up messy and look like this. And I think the big thing is this is a very close and team-based specialty, right? We work very closely with the techs, we work very closely with the nurses, with our consultants, co-residents, our attendings, trauma clerks, and there are hard cases. So after every medical resuscitation, I do think it is good, especially as you move through your residency and become senior residents, to take the time and take the temperature of the room. Whether at the beginning of the room, having people be quiet so you can hear EMS report, refocusing during the middle of a medical resuscitation or towards the end after resuscitation, leaving space for a debrief. If there was problems, if there were concerns, these can be raised so that next time the resuscitations can be run better, or if anybody needs space or time to talk or needs support at that time, I think it really goes a long way towards our wellness and longevity in this career. I know we didn't focus too much on the particulars of the resuscitation themselves, but I think just focusing on what you can do as PGY1s or as sub-Is, and also like what you can do in terms of learning is more important at this point. Next slide.
So getting into the beginning of that trauma bay, you'll see this done out loud, verbalized every trauma bay. I would encourage you to do this for every room in your head. You're just going through, this is like the core of EM, right? You're looking at the airway, looking at the breathing, circulation. Disability is, what's their neurologic status, Glasgow Coma Scale, confused, oriented, things like that. And then exposure, I think, is one of the ones that we really need to focus on to make sure that we're not missing. Trauma bay, you'll see for most trauma bays, they won't progress past this till they've rolled the patient, made sure they get a look not only at the front of the patient when they're laying on the bed, but as well as the posterior. If we go to the next slide, you can see sort of going into the secondary survey, and then we'll talk a little bit about ultrasound as it plays a role in the secondary survey. But really the secondary survey is going head to toe and thinking, doing a good thorough exam of everything there. Thorough, but targeted, okay? You don't want to be spending more than a couple minutes, like 5 to 10 minutes on the entirety of your trauma assessment. And you're trying to find any issues as fast as possible, okay? So going head to toe, listening for breath sounds. You don't need to listen on the belly, just pushing everyone on the belly, feeling for hip stability, looking for any long bone irregularities, any pulse discrepancies, strength discrepancies. You'll get the first part of strength in your initial disability, and then secondly, sort of going through, make sure everything can move. And then going into our next slide, I think ultrasound in the trauma resuscitation bay, we have a standard role for this, going into the fast exam, perfect. Looking if there's any penetrating or blunt trauma, you're going to start your fast exam where the relevant area is, right? If someone's stabbed in the left chest, you're going to start your fast exam with lung sliding. Heart, I would say probably subside, check for pericardial effusion or any cardiac injury, lung sliding after you've done your ABCDEs. I think things that myself and other of my fellow interns had to be reminded first year is that FAST is part of your secondary assessment. You want to make sure you're getting all the way through that primary and making sure you're helping with disability exposure, things like that before you get into this. Focus assessment of sonography and trauma, ultrasound protocol that was studied to look for life-threatening complications and pathologies from trauma. Looking at the subs-eye view and the right upper quadrant view here, these are some of the most high yield views. If someone's hypotensive and it has a positive right upper quadrant, that's enough to get them going straight to surgery. If we go to the next slide, looking through, these are all the views you want to be getting. Right upper quadrant is what we just mentioned, the Morrison's pouch, most sensitive area for intraperitoneal fluid. You're looking at cardiac, pelvis, left upper quadrant, lung sliding, not only up top, but look down at the diaphragm as well. You can kind of cheat that in your left upper quadrant, right upper quadrant. Going to the next slide. It's a pretty small amount of fluid that you need in your intraperitoneal area, and you'll still catch it on ultrasound. That's why this has a lot of utility. And the other thing of sort of getting rapid answers on your lung sliding can help you dictate sort of what interventions do you need for stabilization. And if we go to the next slide, fasting, I think the most important area, when you're in the trauma bay, it's usually because of one of these things. You're fasting hypotensive patients who have blunt trauma, penetrating trauma around that area, looking for indications for surgery that's not already evident, right? And then pneumothorax, looking at your lungs. Next. And then finally, I think some of the things here is when to fast. We review that, right after if the primary surgery has gone well and you have a concern for lung pathology, you can jump on the lungs really quick. But commonly after that primary survey, anytime you have a change in vital signs or patient stability, you can always refast. I think we had a couple cases last year where we had someone who had a negative fast initially on presentation for blunt abdominal trauma, refasted again 10 minutes later as they started to get complain of a little more pain, and then it flipped positive. And that rapidly, that changes their disposition from going to get CT scans and figuring out what's going on to straight to the OR or to figure out what's going on surgically. And if we go to the next slide, I think some things to mention, and I think EM loves ultrasound as a whole. I think it's important to always remember, like Kevin mentioned earlier, ultrasound is a tool. Tools are only as good as the places you're using them and as the user. So, and that's not to refer to specifically like your scanning approach or your scanning ability. It's sort of when you're using the ultrasound as a tool versus when you're going to use the other of the many tools in our toolkits. There's just some information and sort of statistics on for penetrating trauma. Sensitivity can be pretty low. This is really good for blunt trauma, looking for figuring out your next steps. But if you're looking at blunt trauma, you have a lot more haziness. It can be a little more helpful. Going to next one. These are a couple of the probes you will use in your ultrasound training. I'm sure all of you have seen all these probes throughout the course of the year: phased array, cardiac views, linear array, nerve blocks, and ultrasound IVs. Curvilinear is going to be the probe you use for your FAST assessment in the trauma bay, endocavitary appropriately for sort of PTAs and pelvic concerns. Next, getting into the agitated patient.
All right. So agitated patients, common chief complaint that we will see, especially late at night, people who are intoxicated. As a medical student, our priority is your safety. If you are walking into an unsafe situation, you need to step out, call for an attending, call for some help, call for someone who has resources to take care of that patient. Your safety should never be threatened. As an attending, I will not let my residents be in an unsafe situation with a patient. All right, so keep that in mind. Remember that 70% of our communication is going to be nonverbal. So anytime we are going to be dealing with some sort of patient who's agitated, we want to figure out what to say. So the first thing is decide whether or not if your verbal de-escalation is going to be appropriate. Are they responsive? Are they engaging? Is it safe for you to be in a situation to potentially talk them down? Make sure everyone else is safe. Try to get in a relationship and understand what are they there for? What do they need? Is it just that they need a sandwich and they'll calm down, or they just need to be heard? You want to make sure you set limits. I'm speaking in a calm voice. I would like that respect and for you to speak to me in a calm voice as well. Help bring down the tone of that conversation. Enforce, evaluate, right? Set your standards and set your expectations. You know, this is with this. We are trying to take care of your family member. We are trying to take care of your pain right now. I know it's difficult. I need for you to work with me in order to make sure that we're both on the same side and we're taking care of your problem. However, this does not happen well, then unfortunately, some patients aren't able to be truly verbally de-escalated, and then we'll have to go to physical or even chemical restraints on the next slide. Physical restraints are always temporary. These are a bridge to getting chemical restraints on board. Next slide. Chemical restraints are primarily going to be done through medications. Very commonly, we're going to be using IM medications before we get an IV place. Commonly, this can be Haldol, Versed, or Droperidol. Next slide. Sometimes this can also be ketamine as well. Of note, Haldol works pretty well as Versed because they have fast onset of action. But Droperidol is also a drug that is coming back into use within the emergency departments. So this might be a medication you might see as well. All right, next slide. I know that Rahul had spoken previously about the trauma room. So I wanted to take this moment right now to talk about debriefing. I'm sure you guys have seen multiple episodes of The Pit and have seen the absolute craziness that happens. And for any normal person to be able to deal with that sheer volume of chaos, that's incomprehensible. We go through not normal things to be in this job as emergency doctors. And we have to go home to people who don't understand what world we work in. So we have each other to take care of. And culture change begins at home, within our residency, within your institution. So anytime we deal with resusces, traumas, codes, you should always take that opportunity to think and create a conversation. As a med student, you have that ability. It's like, hey, can we talk about what happened during that recess? Because I feel very on edge right now. Say that to a resident, say that to an attending. That can be a great opportunity to initiate a debrief. And really, what is a debrief? Is the idea is a conversation to acknowledge everything that happened and give purpose to the chaos and give value to it, because it's not normal for us to have experienced that. The way I usually go about debriefing as a simulation expert is what we call as a plus delta. Talk about things that went well as things that we can potentially change. Not necessarily things that went bad, just things we can change. Everyone should be able to take some learning points, but I think that debriefing itself can also be changed as well to be turned into what we call as a wellness debrief. Using that opportunity to talk about your feelings, talk about how emotionally charged you are, and also for me as an attending, to open myself up to my staff to let them know that if they are feeling that they need someone to talk to about this case, because that patient, that stroke, that code that we had just now basically was what their father had gone through. And to give them that time to really process that, I think will go miles in terms of making sure their emotional wellness is sustained, and making sure that our job has a certain value of psychological safety to it. All right. With that, we'll go ahead and go for an intermission.
So we'll kind of bring things back here. The first thing I kind of want to talk about, this next topic is going to be how to interact with our consultants. And I think that this is a really important conversation for us, particularly as emergency medicine physicians, because I think we have a unique opportunity to interface with most of the specialties in the hospital on a regular basis. And I think there's a good balance between, talking to the consultants, being respectful and politeful, but also needing to advocate for your patients. And we'll kind of touch on that in a little bit here. But anytime you're talking to a consultant, I think the question that you need to have in mind prior to contacting them is, what are you actually asking them? What do you need from them, so that when you have the conversation, it's not the responsibility of the consultant to like come up with a whole plan necessarily. All right, so kind of a template format wise, if you want to go to the next slide, I kind of progress to the slide, is to follow these steps. Introduce yourself. This is a mistake I made a lot at the beginning of my intern year. I would send the consultant a message with just a blurb of what I thought that they would want to know and what they needed. And their first question would be, who are you? And I think that introducing yourself, one, helps establish that relationship, but two, also helps the consultant frame the conversation. Next, you'll need your opening line and a hook. For me, this is usually a quick information about the patient, their age, their sex, and what the actual problem is. Next, a focused H&P. You don't have to inundate them with all the information, all the lab values. Really try and narrow in on the significant past medical history, vital signs, lab values, and the clinical condition that the consultant would be, that you think the consultant would need to make their clinical decisions. Next is the clinical course. What has already been done for the patient, and what do you think you need to do next? And so a quick example of this is, let's say, you know, I'm Rodan, I'm a EM resident I'm an EM resident at whatever hospital. I've got a 38-year-old male, and I think they might need an emergency scope for a massive GI bleeding. If you use a messaging app or something like that, a lot of times you'll be able to link the patients directly based on room number and MRN. If not, you might have to have that on hand and just kind of type that or call them on the phone and tell them what that is. So in this case, if they have a history of GI bleeding, they have a history of alcoholic cirrhosis with a known varices, they came in for hematemesis, started last night, vital sign wise, soft pressures, 9/60s, tachy's, and they're protecting their airway. So that sentence gives them quite a lot of information, right? It gives them the background of the problem. It gives them the chief complaint. It also gives them a lot of info on the actual current clinical condition of that patient, right? They might be volume down, could be from hemorrhage, right? With the low blood pressures and the elevated heart rate, but they also are protecting their airway, right? They're currently not intubated. And then clinical course, what we've done so far, lab values. If we've got a bleed, we care about their hemoglobin. So initial hemoglobin is 7. It's always good to try and give some sort of context or background to this for acute change. So 2 weeks ago, it was 9. They've been given a liter of normal saline and 2 units of unmatched PRBCs. And then you also want to tell your consultants what you've already started. So Resuscitation, octreotide, Zofran, and then the reevaluation. You've done all of these things. Has that changed any of their clinical condition at all? Next slide. So some tips and tricks when talking to the consultants is really try and know your patient. If you might have all this information on hand, you may not be at a computer all the time when people call you back or message you back, and it's difficult, and they may get upset if they try and ask you a follow-up question, and then you have to go sign into Epic or computer or sit down at a workstation or look a particular lab value up. It's not perfect. You may not know everything, especially on busier days, but it really helps them come up with make their decision too, because they're also on the phone in real time. Second, I think it's important to mention how sick or not sick the patient is. As the emergency medicine doc, you're the one who's physically with the patient. You see them. Everything you're conveying to your consultant is based on your clinical gestalt, and they have to trust what you're saying because they're not physically there. In terms of the story, like I mentioned before, with your focus H&P, the opening line and hook, right? If you're talking to GI, right, and they're worried about a GI bleed, I may not need to tell them about like a patient's acute renal failure or their Beaumont and creatinine or their sodium level, right? Because they don't necessarily need that information at that time to make their clinical decisions. Mention other services that are involved, right? So if the GI bleed, in this case, and you're talking to gastroenterology, you may also want to loop them in if you talk to general surgery, if you've talked to interventional radiology, if you've talked to MICU, just so they know who else is involved in that time. If they want anything else, ask them for recommendations, right? What do you want us to do? Is there anything else you want us to get started? Is there anything else I can help you with? Ultimately, when you're talking to your consultants, be respectful. We're very, like I mentioned before, we're a very team-based specialty. We rely on them, they rely on us. So we're trying to make a quick and good relationship from the get-go. And I think finally, and this is something I'm still working on as a PGY2, is advocating for your patient. Again, you're the only person that's physically there, right? Sometimes, especially at night, we're calling consultants, they may not want to come in to see the patient, but it's going to be your decision, your attending's decision, right? If you really think they need to come in, they may say, no, we can try to admit them, we'll see them in the morning. And if you really don't think that's appropriate, it's important to convey that. And I know that may be hard, especially if you're talking to like a senior resident on the line or an attending in specific, but at the end of the day, we're trying to do what's best for the patient. Next slide.
All right. So we'll go ahead and transition to talking about a few of the emergency medicine organizations that are out there. Next slide. So the big three to kind of know about and be involved with are as follows. So there's SAEM, Society of Academic Emergency Medicine. Conference is actually going to be happening this week. But this one is primarily if you're interested in educational research, getting to interact and network with people who are involved in education or thinking about how to make this, how to evolve our practice, how to teach better as educators, how to teach residents, how to create plans for or curricula for your fellow colleagues. ACEP, American College of Emergency Physicians, is primarily the organization designed around the success of the emergency medicine practice as a whole. So it's a little bit more corporate behind that. AAEM is American Academy of Emergency Medicine. This organization was born out of the desire to give emergency physicians what they need to do well at their job. So one is more kind of corporate based, and one is more EM physician mentality mindset based. All of these have their own specific resident and med student association. RAMS for SAEM, EMRA for ACEP, as well as AMRSA for AAM. So these are all opportunities to be involved as a representative for your school, as well as network and be involved as a med student representative or to network with other fellow medical students out there. These opportunities that can arise, especially through RAMS, they have mentorship as well as sponsorship, mentorship hours, where you are able to meet with people who are might be able to help you go further in your field, whether you're a medical student and you're trying to get some ideas for people who, like potentially through APAMSA, help give you ideas of how to best find your rotation, create your rank list, or if you're interested in a specific field of emergency medicine, help jumpstart that pathway for you.
All right, so real quick, just to touch on some resources to use. Whatever program you're at will have their own curriculum, whether they follow foundations, some things program specific, and each of them will have their own links and resources. I think the most important thing, because there are so many, is just pick something and be consistent with it. A lot of it, especially when we're talking about bread and butter emergency medicine, AFib, CHF, ACS, it's all sort of protocolized, has templates, and has things that we can follow. And I'll send a link to to you guys with a list of resources and things, so you don't have to like look for all of these particular podcasts and texts. Some of the podcasts that I really liked, the EM Crit podcast and EMRA, they have kind of weekly/monthly based podcasts that keep you up to date on changes in emergency medicine, and I can do research and treatments, but also have like a backlog and archived stockpile of things that you can review for, again, bread and butter EM cases. In terms of websites, the two that I probably like the most, Life in the Fast Line, Life in the Fast Line goes over EKGs really well. The bull icon in the bottom right is an app called EKG Stampede. It's really great for triaging EKGs. It's free. It gives you 10 that you're supposed to find a STEMI, 2 unstable patients, 2 stable patients. I think it's really applicable. We can handle a lot of EKGs every day. And then in terms of texts, if you're a textbook fan, I think you can't really go wrong with Tintinalli's or Rosen's. I have both of them. I thought I would be super productive and read them all like during intern year, and that was absolutely a lie. And I think I'm open to zero. I've read maybe one paragraph in both of those textbooks. Next question or next slide. But I think the big thing I want to touch on here with resources is like AI, right? Because I think right now it's been very popular. I went to Cord this year, and this is the keynote speech is all about AI, how it can help us. Two things I want to touch on: open evidence. If you are a PGY1, let's go back one slide real quick. PGY1, once you get your NPI number, you can log in and have access to it. As med students, I believe there's still a med student option. It's free. It's great to ask it any medical question, right? If you're worried, if you want to know about antibiotic dosing protocols, if you can't remember the Berlin criteria for ARDS or any of those things, it's great to ask. I think my one caveat to anything with AI is don't let it be too much of a crutch. If someone is acutely ill, you do not have time to look this up and do open evidence. You still need to develop your clinical gestalt, and you still need to develop your own bank of knowledge in your head. This is great to help, but you need to know all these medication doses and things. Like there won't always be time to use it. I think two great times to use it, if you want to go to the next slide, is one, how to talk to families. It's hard to break down some of the tests and the things that we do. So one thing I'll ask is like, hey, how do I explain DIC like I'm 5 years old? It'll give you a laundry list of things, and now you can break down lab values or tests or disease processes to patients and their families to help them understand a little bit more about what's going on. Next slide. Another thing is discharge instructions. Epic has a lot of stuff already built in, or whatever EMR you use will probably have a lot of dot phrases and things already built in, but we have a PTD. There's sometimes little nuances, or maybe ortho told me a particular thing I don't remember. I'll look at open evidence for particular discharge instructions and pearls I can also give the patients. Next slide. Other thing I want to talk about is a free app called Notebook LM. It's through Google. You can put in journal articles and your research, and it will create podcasts and mind maps for you. So next slide. I think this is useful for Journal Club because you put the journal article in and it makes a podcast. So on the way to Journal Club, because all of our attendings live like 45 minutes away, it'll just make the podcast and I'll listen to it on the way there. Still good to read the article because it's not a perfect podcast, but it gives you like general results, methods, findings, in a nice conversational form. Next slide. The other thing that it's really good for is mind mapping. If you give it multiple articles, it'll start generating maps and of concepts and ideas. So if you have a research project or are trying to do a lit review, I think it is super helpful as a database.
All right, choosing a residency, very big topic, but fortunately I do not have that much time for it. A lot of things that I would like for you guys to consider, other than specific value of training. It looks like most residencies are going to be going to a 4-year program anyways, so duration probably is not going to be on the table anymore. Other things I would like you guys to consider is how happy are the residents? You're going to be there for 4 years. If they're not happy and all they say is we're just working hard, it's not going to be good. But I think that sometimes besides the training, other things that do matter for you, you guys are going to be now working adults, is sometimes perhaps pay and how much the program is going to add potentially stipends for housing or for pay or for potentially lift or additional charges during residency. These are money, like at the end of the day, money is a big issue for people, especially when it comes to wellness, especially if you live in New York City. So being at a program that makes sure that you're financially well, as well as mentally well, in addition to the training that you're getting, is going to be things that you guys should consider. Additional stuff that will happen during residency, next slide, are potentially the discussion for what fellowships are. Now, as a medical student, someone going on their sub-I, this is certainly beyond your scope. These are absolutely things to consider once you're a resident, potentially to expand your ability as a physician, to add a new skill to your repertoire, and potentially get buy down for having less clinical hours by doing all of this other stuff. All right, next slide. I think I already talked about this. Next slide. first impressions matter. So how useful can you guys be as a sub-I? At the end of the day, when you show up to your shift, you want to be the first person and introduce yourself to your team. When I deal with a medical student, I would like for them to come up to me as being like, as opposed to finding out who is this person. Go up to them, say, "Hi, I'm a medical student. I'm coming from this university. I'm currently a MS2 or MS3 or MS4, and this is my sub-I. I would like to learn a lot, and these are the things I would like to work on." Giving your attending an idea of what you're interested in, as well as things that they can potentially teach or find for you to learn from, shows that you are proactive. Next slide. I'll show you now. We'll go back. So again, with the first impressions, a lot of the times that I will have issues with medical students are when they're not being proactive about seeing the board. At the end of the day, I don't necessarily expect you to be functioning like a full end of first year resident or potentially a second year resident. But I do expect you to see patients, to be proactive, and to learn from them. Going on and when you see your board, I know getting used to Epic can be confusing at times, especially if you're going to different locations. But once you familiarize with the system, taking the time to proactively see when patients show up on the board and say, "Hey, Dr. So-and-so, Dr. Han, I would like to go ahead and see this patient. Is that okay with you?" And then go see them. And when you come back, have your presentation kind of in your mind. Don't necessarily need to write down everything, but because at the end of the day, you want to make sure you have a very concise oral presentation that you're going to get the attending. Start off with what's very pertinent in terms of their history, physical. I don't need to hear the full end of M2, H&P about what their family history is, what they ate yesterday. It's not relevant. And frankly, you've lost me. If you can't tell me or convince me about what this patient has within 2 minutes, and also give me a pretty focused differential, then you've already lost my interest. And I think you're not going to rank as high as some of the other students who have really given that thought to make it concise and to the point. All right. Next slide now. So where does the future of emergency medicine going? I know that in the past that there was the jobs report saying that there were something around 10,000 less jobs. But at the end of the day, we are having a lot more jobs appearing in emergency medicine. This job is the best job. I love going to work because of my patients at the end of the day. It's rewarding, it's challenging. One of my chairmans that I had spoken with said that, like, at the end of the day, emergency medicine is the last bastion of being what a true doctor is. We see the undifferentiated patient, and we get to figure out what's going on and do real doctor stuff. This job itself covers a whole breadth, whether you're at a community site, county site, or at an academic site. We are still, wherever we are, the safety net of our healthcare system and well positioned to lead in social medicine. And for that reason, that's why ABEM boards are changed. ACGME has recommended that residencies now switch to the 4-year program to include social medicine, telehealth medicine, addiction as part of additional subjects or electives that are included within our scope of emergency medicine, because that is where we are going. Most of us should get urgent care experience. Some of us are going to be leading, like working at City MD or any of the other urgent cares locally. And that's where our skills are needed. We as EM physicians, we are the jack of all trades, master of none, but better than master of one. And so being in the position of an emergency physician gives us the opportunity to have a lot of access to critical care procedures, but also be the healthcare navigator for not just our patients, but for the rest of the people that we work with in our system, EMS, as well as the people upstairs. And yeah. All right. So again, thank you all for attending. We got about 25 minutes-ish left. I'd like to take this time to, again, thank all of the people who have been a part of this: Sai, Rohan, Rahul, as well as the rest of our APAMSA leaders here. But thank you all for coming. We have this now kind of open for you guys to ask us questions